Hello, everyone, and welcome. Welcome to the SRHM Special Issue Launch webinar. My name is Neha Raval, and I'm a Senior Program Officer with the Program on Global Health, Justice, and Governance at the Mailman School of Public Health at Columbia University. We'll start with just a few housekeeping items. For the webinar today, please choose your preferred language, English or French, by clicking the interpretation button in the bottom right corner of your Zoom screen. You must choose English or French, as the webinar will include presentations in both languages today. If you have any questions for the presenters, please enter them in the Q&A feature at the bottom of your Zoom screen as well. Please note that this webinar will be recorded. We will have the recordings available for all audience members in both English and French available. As a reminder, the chat function will be turned off, but if you have questions, please put them in Q&A. And make sure you choose your language before we begin, English or French.
Si vous préférez écouter le webinaire en français, il faut sélectionner Interprétation là en bas à droite et sélectionner le français.
Thank you. And now I'm going to introduce our first speaker. Our first speaker is Mr. Anand Thamung, co-guest editor of the Sexual and Reproductive Health Matters Special Issue. Mr. Thamung is the founding director of Center for Research on Environment, Health, and Population Activities, or CREHPA, based in Kathmandu, Nepal. Mr. Thamung has over 39 years of professional research experience. He and his organization, CREHPA, work extensively on abortion-related research studies and use the research results for advocacy to influence the national policy. I'll now hand it over to you, Anand. Thank you.
Hello. Good morning, USA. Good afternoon, Europe and Africa. And good evening, Namaste, Asia and the Far East. I would like to welcome you all at this launch of the special issue on sexual and reproductive health matters. As you have seen on the screen, the title of this special issue, so I don't want to repeat that. As you all know that President Trump reinstated and broadened the GGR that not only impact the international family planning programs, but also the broader field of US global health assistance. NGOs refusing to sign the GGR not only lose the funding, but also alienate from coordinating with other sub-grantees and partners. This special issue is dedicated to eliminating the harms done by the expanded Global Gag Rule, which tramples on national sovereignty, sound health policy, and women and girls' sexual and reproductive health and rights. Our webinar agenda runs as follows. We have a research review, then there will be a presentation by the 3 country PIs, Nepal, Kenya, and Madagascar. This will be followed by a moderated question and answer session. Then there will be an overview of the in-country dissemination activities and the commentaries that are in the special issue. Then there will be a closing remark. The entire webinar we hope to complete by 1.5 hours. So now I would like the session to begin with an overview of the research by Terry McGovern. Now let me introduce Terry. Terry McGovern currently serves as Harriet and Robert H. Heilbrunn Professor and Chair of the Heilbrunn Department of Population and Family Health, and the Director of the Program on Global Health Justice and Governance at the Columbia University Mailman School of Public Health. Ms. McGovern founded and served as an Executive Director of the HIV Law Project and was Senior Program Officer in the Gender, Right and Equality Unit of the Ford Foundation. So, Terry, now it's yours. Thank you.
Thank you so much, Anand. I guess I'll wait for my. Thank you so much, Anand. Welcome, partners, colleagues, and friends. We are thrilled to share 3 years of extensive research about the Global Gag Rule today. Thanks to the generous support of the William and Flora Hewlett Foundation and the David and Lucille Packard Foundation, we have developed a really unique body of research led by partners in Nepal, Kenya, and Madagascar, who you will hear from today. I'm not sure if my image is supposed to be showing. Okay, central to the effort has been collaboration. We have supported in-country dissemination activities led by our partners and stakeholders. We co-led a robust research working group with Change and brought researchers and advocates throughout the project together, including a 2019 Istanbul strategy meeting with advocacy and research partners from all 3 countries. We co-hosted a side event with the Global Fund for Women at the Nairobi Summit, ICPD +25. The Global Health Justice and Governance Program is a university-wide initiative housed in our department, which prioritizes country partner or local leadership and interrogates the harmful role of and impacts of global governance. And by governance, we mean governance in its broadest sense. We consider funding restrictions like the GGR, the decisions about what data is required to be collected and that which is not, standards imposed by donors as governance and justice issues. We look at structural barriers to the creation of accurate evidence, if you will. The Global Health Justice and Governance Program advances justice in the areas of gender, environment, and food. The program integrates public health, legal, and scientific scholarship and practice from across Columbia University and the world. Now, Anand talked about the GGR as a policy. Just a couple of additional points on that. Past iterations of the policy only applied to US family planning assistance, about 500 million during the George Bush administration. Under President Trump, it now applies to all global health assistance furnished by all departments or agencies. So now we're talking about 11 billion. So this expanded GGR affects not only international family planning, but the broader field of global health, HIV, malaria, TB, nutrition, WASH, and other health areas. And its ramifications have been extensive, and you will hear about that today. I want to briefly describe the global paper. We looked at global SRHR surveys, laws, and conducted interviews with global multilateral actors. And before we get into the countries, I want to talk a little bit about this. Global estimates of abortion are largely inaccurate. Stigma leads to underreporting across legal contexts, and the availability of medical abortion outside the formal health system has further complicated tracking. Our estimates of unsafe abortion are particularly poor. There are particular gaps related to abortion incidents in low and middle income countries, despite the fact that abortions taking place in these countries has increased. Cause-specific data for maternal mortality are limited, especially for countries with high mortality levels. Disaggregated data about abortion based on ethnicity, race, and migratory status is poorly captured. Most data only consider women 15 to 49 years of age. No data for abortions in people younger than 15 years of age, or very little. Significant gaps in data for unmarried women. Actually, and most of the available data focuses on maternal mortality associations with complications, very little on morbidity. Criminalized populations are also missing. As we document extensively in this paper, safe abortion is a recognized component of sound healthcare and the right to health. but global governance remains extremely weak, and multilateral actors fail to adequately monitor abortion. This lets countries off the hook with regard to these data. As a matter of effective global health policy, countries need to track and monitor what's going on, what drives illness and mortality, and have transparency about government program performance. This is called scientific advancement. However, with abortion, global and local actors disregard these principles. The MDGs do not track access to safe abortion and death due to unsafe abortion. The Sustainable Development Goals Indicator 5.62, which is looking at to increase the number of states with laws and regulations that guarantee women access to sexual and reproductive health care, does not track access to abortion. Many of the surveys and frameworks developed by multilateral actors either ignore abortion as a component of SRHR or solely track the legal status. This is true for the DHS surveys, which are nationally representative surveys every 5 years by USAID and ICF International. Also, the service provision assessments leave it out. WHO's work on abortion is more robust, but is limited to those countries selected to participate. As we describe in the paper, there are glimmers of hope. However, multiple interviewees in all categories noted that the US is actively retreating from human rights commitments and trying to roll back any consensus related to sexual and reproductive health. In withdrawing from the UN Human Rights Council, removing the reproductive rights section from the State Department's annual human rights report, and urging a limited interpretation of SRHR in UN fora, the US government is threatening fragile gains related to comprehensive sex education, sex work, sexual violence, and adolescent health. The US government has significantly curtailed data collection related to sexual and reproductive health. As one of our interviewees said, the US government is no longer reporting on and collecting stories and data and information around human rights violations related to access to family planning. We will miss a not insignificant amount of the impact data because we are not looking, they're erasing. There is broad ongoing concern that the GGR is creating a hostile climate for research, undermining efforts to link science to sexual and reproductive health. What they call the sensitive political environment, one interviewee noted, was really used to justify an unusual level of involvement of the donor in our research. You know that with the reintroduction of the Global Gag Rule, said another interviewee, it's really reframing abortion access as a political issue, whereas for us, it's 100% a medical issue. Several respondents stated that out of a desire to avoid causing trouble, USAID staff had censored the content of peer-reviewed articles. Multilateral organizations, such as UN agencies, are not bound by the GGR, but several affiliated respondents reported they are self-censoring so as not to raise the ire of the US government because of all the money, 11 billion, the world's largest donor, that the US wields. Another respondent reported that the organization routinely excises the word abortion from policy documents and commitments, even though there's no formal obligation to do so. Another saw the failure to track access to abortion under the indicator of the Sustainable Development Goals as a direct result of the Trump administration's hostility to abortion. On a more granular level, multiple interviewees reported that organizations that sacrifice US funding by refusing to sign on to the Global Gag Rule are excluded from global standard or agenda setting meetings, as well as conference panels on SRHR related topics, despite being critical to the conversation. Lastly, interviewees describe the Global Gag Rule as destroying years of progress. For the last 20 years, said one speaker, the whole development community has tried to increase efficiency in the health sector and has worked towards integrating services, reducing vertical funding, trying to create one-stop shops where patients could come and get the full service that they need. I think the big inefficiency with the Global Gag Rule is that it goes against this trend and rolls back work of 20 years. So with that, I will turn it over to our Senior Program Officer at Global Health Justice and Governance, Emily Mastrelius, will present the project overview and methodology.
Thanks, Terry, and greetings all. Before we hear the research presentations, as Terry just mentioned, I'm just going to give a brief overview of the methodology followed in each country and talk a little bit about why we selected Nepal, Kenya, and Madagascar for this research. So in this work, we were guided by the overarching research question: how does the GGR affect provision of and access to sexual and reproductive health services? And research teams conducted semi-structured interviews with participants in different categories listed here in order to capture the effects of the GGR at different levels of the health system. That said, as the research presentations will illustrate, there's some variation in participant categories across countries. So the articles in the special issue do not necessarily include all categories listed here. But one of our aims was to expand upon the participant categories that have been included in previous research on this and former iterations of the GGR in order to surface a broader understanding of the policy's reach and influence within country health systems. So at the government level, we asked questions about relationships between the US government, the Ministry of Health, and civil society, about national sexual and reproductive health priorities, supply chain, and the implementation of public sector strengthening initiatives. At the NGO level, we asked about communication about the GGR, as well as changes in funding and changes in organizational policy, program management, and administration. And at the facility level, interviews focused mostly on changes in staffing, commodity supply, and service delivery, while with clients, we focused more on changes in accessibility of services, cost, choice, and quality of care. Next slide, please. We deliberately selected these 3 countries for this research because we wanted 3 countries that differ significantly in terms of legal status of abortion, as well as the amount of US global health assistance received. And this slide highlights some key differences between the 3 countries. In Nepal, the abortion law has been more permissive than the GGR's exception since 2002, when abortion was made legal on demand for the first or through the first 12 weeks of pregnancy. A 2013 study found that only 44% of women were aware of their abortion rights, however, and in 2018, the law was further expanded to permit abortion on, up to 28 weeks in cases of rape, fetal abnormality, and or threat to the life of the pregnant person. While the Kenyan constitution permits abortion to protect the life or the health of a pregnant woman, the circumstances under which abortion is criminalized in the Kenyan Penal Code are much less clearly specified, and that creates confusion among providers and among women. Madagascar has one of the world's strictest abortion laws, with consequences for women who have abortions for any reason, as well as for individuals who assist women in obtaining them. In terms of global health assistance received, all 3 countries depend upon significant amounts of bilateral health and reproductive health funding from the US government. And as you can see in the bottom of the table shown on the slide, over 50% of official development assistance for population policies and programs and reproductive health comes from the US government across the 3 countries. However, Madagascar does stand apart in that Madagascar is considered a donor orphan compared to the other 2 countries. And as you can see on this slide, Madagascar also has the highest maternal mortality ratio and the lowest contraceptive prevalence rate of the 3 countries. So again, just a very brief overview. Now I'm going to pass it back to Terry to introduce the research presentations and dig into these results. Thanks.
Thank you, Emily. I also want to throw in a thank you to our amazing students who supported this whole project, Naomi Gaspard and Maggie McGee. I have the great pleasure now of introducing our first research partner. Our research partner in Nepal is the Center for Research on Environmental Health and Population Activities, or CREHPA. Presenting the research finding are Josna Tumang, Research Associate, and Agi Kunal, Field Officer. I turn it over to you. Thank you so much.
Thank you, Terry. So I will be presenting the findings from Nepal's study. So the title of our paper is Foreign Ideology versus National Impacts of the US Global Gag Rule on Nepal's Sexual and Reproductive Health Care System. Next, please. So our study was carried out in 2 phases, which covered, and we covered 22 districts in 7 provinces. Next, please. In both the phases, a total of 205 semi-structured in-depth interviews were carried out, with the highest number of interviews carried out with the NGO program managers. In phase 1, we interviewed 52 NGO program managers, of which 13 were from certifying NGOs. And in phase 2, we carried out 32 interviews with NGO program managers, of which 13 were from certifying NGOs. There was significant overlap in the NGOs and facilities in both phases, although participants interviewed during phase 1 were not necessarily interviewed in phase 2. Next, please. So for the findings, I'll start by talking about the knowledge of participants and then discuss the impact on civil society collaboration and SRH service delivery. Our findings show that about half of the participants had heard about the policy. Knowledge was obviously highest among the NGO participants, especially those who were from the certifying NGOs. But however, even among the participants from certifying organizations, knowledge varied. Some were able to provide description about the policy, while others were not aware of the policy in detail. Few also demonstrated misunderstanding of the provision. So such lack of awareness and understanding of the GGR had caused confusion among the certifying NGOs, and few participants described how long the contract was and how it was difficult to understand. Another participant mentioned an incident in which they had almost violated the policy due to their lack of understanding. The participant told us that my organization has been implementing USG-funded projects for several years. We were accepted by another organization to implement their abortion-related program in the district. When we advertised for staff vacancy in the local media, the manager of the prime organization issued a letter saying that we had to choose between the 2 projects. Of course, this organization withdrew their agreement with the non-certifying NGO and preserved their USAID funding project. Next, please. So NGOs that did and did not certify the GGR reported that their participation in the SRH technical groups, program coordination meetings and trainings had changed after the policy was reinstated. Participants were reluctant to join meetings that included abortion-related discussions. There were some participants from certifying organizations who chose not to attend the meetings or training that included abortion on the agenda, while there were others who also attended but took care not to speak during the conversations regarding abortion. They described fear that their presence in these events could easily be misinterpreted. So there was also participants who mentioned that they are not even going to say abortion, the word abortion, use the word abortion. Participants from GGR certifying NGOs lamented lost opportunities to coordinate activities with non-certifying NGOs, where they have mentioned that they cannot support those NGOs working on abortion or coordinate with these NGOs. Next slide, please. On the other hand, few certifying NGOs shared experiences in which they were excluded from the government settings or that were relevant to their work because of overinterpretation of the GGR. As in the verbatim, in one instance, a non-certifying NGO wanted to provide information during a training being held for service providers from public health facilities. This training was funded by USAID and organized by the district health office. So the district health office had told them you can either hold the session before the training or after the training. However, the USAID funded program manager told them not to talk about abortion during this session. And just to provide information that this organization works both on family planning as well as abortion issues. Next slide, please. In terms of impact on organization sustainability, we found that non-certifying NGOs explained that their organization had stopped applying for large USG grants that they would have otherwise sought, making it more difficult to financially sustain their organization. A US-based NGO on SRH had replaced partners who decided to certify the policy, thus facing project delays. This NGO lost about 3 community partners who certified the GGR in order to maintain the USG funding, while the US-based NGO was able to replace the partners in 2 of the districts. They had to stop activities in 1 district, which meant that they had to start the recruitment process again. Data from the phase 2 shows that few NGOs were beginning to experience early effects of the Pompeo expansion on NGO partnerships. One NGO participant described receiving a letter from the Global Fund Prime Partner that asked for confirmation that the organization did not conduct activities prohibited by the Global Gag Rule policy. Another non-certifying NGO participant who worked on safe abortion reported being informally told by the Global Fund Prime Partner that their organization would soon have to choose between continuing to receive Global Fund funding, or implementing safe abortion activities. Next slide, please. So now the findings on impact of service delivery will be presented by my colleague Agya.
Thank you, Jyotsna. Now we will be talking about the impact on the referral networks. A handful of participants from certifying NGOs and affiliated facilities stated that they no longer provide abortion referrals to non-certifying facilities. For example, one of the organization removed a non-certifying organization from their referral pamphlets in order to remain. Next slide, please. Thank you. So a handful of participants from certifying NGOs and affiliated facilities stated that they no longer provide abortion-related referral to non-certifying facilities. For example, one of the organizations removed a non-certifying organization from their referral pamphlets to remain compliant. Furthermore, 3 certifying NGOs stated that the organization do not make any abortion-related referrals, even in case of rape, incest, or if the life of the pregnant woman is in danger, which are exception allowed by the policy, as they fear that in doing so, they would be found out of the compliance. Similarly, there were organizations who purposefully over-restrict family planning activities and gave the impression that this was done to avoid policy-related scrutiny. One of the participants from certifying organizations stated that we do not touch any part of SRHR even though we are allowed to talk or refer our family planning. Our finding also indicate that the facilities which received referrals from certifying NGOs no longer received the referrals from past 1.5 to 2 years preceding our study. Next slide, please. Here we will be talking about impacts on various non-certifying organizations and facilities. CIFPO2 project supported by USAID intended to help Ministry of Health and Population in Nepal to achieve MDG 5 by increasing access to quality family planning services. The 2 large NGO implementing this project since 2016 were unwilling to comply with the terms of GGR. And as a result, the CIFPO2 project ended earlier than the scheduled time. Representatives from the 2 non-certifying organizations from our sample district also stated that there was extensive layoffs of program administrator, managers, health workers, and community volunteers when the policy rendered them ineligible for the USG funding. Similarly, one of the NGO was forced to close down 7 of the community family planning clinics that extensively served thousands of clients for family planning services, including emergency contraceptives. Next slide, please. Next we have is the impact on public sector. The early closure hindered support for family planning outreach services that previously served approximately 16,000 people in late 2017. The early closure also meant that family planning behavior change communication activity in the community had decreased. As a result, governments were not able to organize such mobile outreach in late 2018 due to lack of resources. CIFPO2, which was meant to build family planning capacity in government health system with all activity gradually transitioning to government control. However, early closure of the project had a negative impact on this transition process as well. Several NGOs and government representatives stated that the sustainability planning and the handover process was insufficient. For instance, there was absence of continued on-the-job training following the end of CIFPO2, which resulted in lack of confidence among the service providers to provide large services. Next slide, please. Now talking about our conclusion. In conclusion, our findings shows that low policy awareness and considerable chilling effect cut across level of Nepali health system. NGO funding losses and disrupted partnership and networks at multiple levels further constricts access to family planning, safe and legal abortion services, which ultimately undermines the ecology of SRHR service delivery in Nepal, as well as our national sovereignty. Thank you.
Thank you so much. It's kind of hard to maintain composure that these findings are so upsetting. This is why we're calling it exporting harm. Thank you so much. Our research partner in Kenya is the African Population Health Research Center, or APHRC. Presenting the findings are Boniface Oshie, Associate Research Scientist, and Grace Kimem-Iya, Research Officer. Welcome and thank you.
Thank you, Terry. My name is Grace Kimemia from APHRC, and I will take the first part of this presentation. So we are presenting the findings from our recent study, and the paper that was published from that finding is titled Foreign Assistance or Attack, Impact of Expanded Group Gag Rule on Sexual Reproductive Health and Rights in Kenya. This was published in August 2020. Next slide. The study sites were Nairobi, Kisumu, and Busia counties. These counties were chosen because of the existing knowledge that some of the NGOs that are located in these locations will be impacted by group gag rule, and also the feasibility and variability of having different participants. The next slide. So study participants from the NGOs were US-based NGOs and also non-US-based NGOs. For US-based NGOs, we managed to interview 5 participants. These are program managers, directors, or country leads in those NGOs. And non-based NGOs, we managed to interview 13. Out of these 13, 4 was certified GGR. 2 had not satisfied GGR at the time of the interview, and 7 had no US funding at the time we interviewed. That is back in 2018, 2019. And for health facility level participants, these were drawn from both Busia and Kisumu, and from both public and private facility. And you can say we managed to interview 12 facility managers and 25 service providers. Now I'll hand it over to Boniface to go into details on the results. Thank you.
Thank you very much, Grace. Next slide, please. So these are some of the results that we have from this study. And the first one that we want to share with you is that the Global Gag Rule strengthened the anti-abortion contest in Kenya. Kenya is a setting where abortion is a controversial and sensitive issue. So the Global Gag Rule has given impetus to the opposition, that the groups that are opposed to abortion, to say, well, typically people think that the global north is the one that brings in a foreign agenda of abortion to Kenya. But now that the government of the United States is now against abortion, then the people in Kenya become emboldened to oppose abortion. And of course, we found that even the government of Kenya is not saying anything about it. And the reluctance to say something about it is because the government receives a lot of funding from the government of the United States, and they don't want to upset the US government. So with this whole situation of the Global Gag Rule, activities from opposition groups like civil societies opposed to abortion or religious organizations have become increased. Here's a finding from one of our interviewers, a US-based NGO, which says that the Global Gag Rule has created divisions, so that the biggest effect we've seen now is increase in what we call opposition to abortion access. So the groups that are anti-choice are invigorated by this Global Gag Rule. It's given them momentum. There is new vigor in the opposition groups. Next slide, please. So whereas people used to be a little, the opposition's group were not as strong as they are now, the Global Gag Rule has made its. We also found that the Global Gag Rule creates a chilling effect on the civil society. Overall, it disrupts the civil society, as you heard from my colleague in Nepal. Collaboration and partnership between civil society groups that used to work together has now become very difficult to have, because organizations that have signed the Global Gag Rule are finding it difficult to work with those that refuse to sign the Global Gag Rule. And apart from that, even within the organizations that have signed, it becomes difficult for them to free themselves up to do even services that are allowed under the Global Gag Rule. So even if they want to do something, they self-censor. In fact, they self-censor themselves, they overinterpret the provisions of the Global Gag Rule, and as such are unable to provide services that they should normally provide. And then for organizations that do not sign the Global Gag Rule, it becomes even more difficult for them to have relationships with organizations that have signed. Whereas in the past, these organizations used to refer clients across board for services. So for example, an organization that is providing long-acting contraceptives may have clients referred to them by organizations that are not able to provide that service. But because of this dichotomy of certifying and not certifying the Global Gag Rule, that relationship is no longer there, and therefore it's not possible for people to organizations to refer. Next slide, please. Okay, so apart from having this level of impact, we also saw that the Global Gag has direct impacts on organizations and directly on the health system. So for organizations, we see that one of the biggest impact is that they have lost funding that they need to implement their SRO-HRO activities. We see that those that have signed, those non-US based organizations that did not sign the Global Gag Rule, they are now unable to receive any kind of sub-grant from organizations that have signed. And so on. So it becomes difficult for organizations to decide whether they want to do their usual SRO-HRO services, including abortion, family planning, or they go for US funding. If you go for US government funding, then you have to forfeit the programs that you really will want to provide. So here is an example of a quote that we have from a non-US based organization. They said that their US-based prime just informed me, if you want our US government money, forget about your grant from the other donor that the funding that they use for family planning and for abortion. So I had to make a conscious choice. Which one do I drop off? So that's how it affects my work, because we are so torn in between. And we also see that most of the organizations now, people, whereas they were spending more time implementing programs, they now spend a lot more time fundraising against implementing programs. Next slide, please. We also see that the Global Gag Rule has impacts on the service delivery. We know that the integration of HIV and SRO-HRO services have been canvassed for a long time, but we know that because of this demarcation between HIV on the one side and other SRO-HRO services that include abortion on the other side, that hope for integration is no longer there. It disrupts services, and as we've said, it disrupts partnership. Next slide, please. We also found that apart from that, the impact at the organizational level, NGO level, but there is also impact at the health facility level that impacts directly women and girls who need services. We know, for example, that there is shortage of staff, an increased number, and a decrease in the number of staff that have been trained on the services, especially by NGOs that typically support these health facilities. We know from our research that there's frequent stockouts of family planning, commodities, and supplies. And all this is because of the difficulties that the Global Gag Rule has brought about, even with the government. Before, where the government was feeling unsure or was not interested in providing abortion services, the Global Gag Rule is already ensuring that government is following up through that process of not providing services. We know that shortage of staff is not a new thing. it's been here, but we found that the Global Gag Rule actually compounds this problem. So we think that based on our study, we think that the Global Gag Rule is actually, instead of bringing foreign aid, it's actually bringing foreign harm or foreign attack. Thank you very much.
Thank you. Thank you very much. Thank you so much. And we're going to come back to questions. Our research partners in Madagascar is the National Institute of Public and Community Health, or INSPC. Presenting the research findings is Mom Razafi Mahatratra, research assistant. All audience members must select English or French from the interpretation menu on the bottom right of your Zoom screen. Welcome, INSPC.
Merci beaucoup.
Thank you so much. It's a great pleasure for us to present to you these results of the research that we carried out here in Madagascar that we entitled Slowing the Progress, U.S. Global Gag Rule Undermines Access to Contraception in Madagascar. Next slide. So Madagascar remains, unfortunately, one of the poorest countries in the world, with many hard to reach rural areas. And for these health services, the country depends heavily on foreign aid in the area of reproductive health. Its main donors are represented by UNFPA and USAID. For contraceptive services, the main partner is a large non-US NGO that supports contraceptive service in districts throughout the 22 regions of the country, and which focuses on remote rural areas and poor or young populations, and works through a network of private providers, and also provides support to public health facilities, and works through mobile clinics to do outreach work. This large NGO lost substantial funding from the US government when the Global Gag Rule was introduced. Next slide. We interviewed key informants in the capital, Antananarivo, and also in 8 districts across the country. We interviewed participants at different levels of the health system, including the Ministry of Health, NGOs, providers, community health workers, and contraceptive clients. Little difference was found between the results of public and private providers. So when I refer to providers in the rest of the presentation, this will mean public facilities and private health facilities, unless I specify otherwise. Next slide. So when the partner NGO, this main NGO, did not sign the Global Gag Rule, it lost its financing from USAID towards mid-2007. It had to reduce its funding to its usual partners. More than 100 public and private, 90 private health structures. You can see in this chart the causal structure on the health system of this loss of financing. The next slide that we'll see presents the main interviews. You can see white for English and yellow for French. Next slide. So the representatives of the Ministry of Health at the district and regional levels deplored the reduction in the number of public health centers that received contraceptive support from the NGO. Several providers mentioned the reduction in visits provided by this large non-certifying NGO and the resulting impact on, number 1, contraceptive prevalence, and number 2, the number of women visiting with unintended pregnancies. Next slide. Providers described reductions in staff allowances, reductions in training, reduction in supplies, and also supervision due to the loss of US funding by this NGO. They are worried about the reduced quality of care that they were providing as a result. Next slide. Participants described problems with the contraceptive supply chain across Madagascar that were already a persistent national problem, but that were further exacerbated by this global gag rule. Several public providers reported that this large NGO that was non-certifying had supplemented their supplies from the Ministry of Health by providing a buffer stock to avoid stock shortages. However, once the support was finished, they also experienced stockouts in several methods. Others mentioned that they had to ask clients to pay for their method when they lost NGO support. And yet, it used to be a free service. Many providers talked about the way that this situation led to high levels of frustration among women and a loss of confidence and trust toward them and towards the health services in general. Several providers talked about an increase in undesired pregnancies, and this led to more prenatal visits and an increase in clients who come for care after or post-abortion care. Next, the vast majority of clients surveyed reported increased difficulties in obtaining their preferred methods. Some reported a different experience each time they came for their next dose.
This made it difficult to continue using the method continuously. Sometimes it was available. Sometimes they had to go to a pharmacy to buy it. And sometimes they simply had to stop using contraception, or they had to change methods because they could not find it at all. Increasing costs were a common barrier. Some women reported having to choose between using contraceptives and buying food for their families. Next slide. Women also described their frustration with service providers who could not explain why they did not have their expected methods or when they would be available again, or even explain why they had to pay more for the same methods that they had already been using. Many women explained that they, as well as other women that they knew, had experienced an unwanted pregnancy because they had had to stop using contraceptives. Some of them had ended their unwanted pregnancies. Next slide, please. In conclusion, in a country like Madagascar, which relies heavily on donor funding for its health system and the US government for sexual and reproductive health, the impact of the global gag rule has been devastating, despite the fact that the country has a more restrictive abortion law than the GGR. Although the GGR ostensibly concerns abortion, it has actually also reduced access to contraception, and it has increased inequalities within the Malagasy population. This study is one of the few studies that have documented the direct impact of the global gag rule on women, who themselves described their difficulties in being able to obtain contraception, difficulties that ultimately led to the cessation of contraceptive use, unwanted pregnancies, and also, in some cases, unsafe abortions. So, ladies and gentlemen, thank you very much for your attention. Thank you very much.
Thank you so much, Mom. Now we're going to have a 30-minute question and answer session. I'm going to ask a few questions, and then we're going to hear some of the audience questions. My first question is for CREHPA. Did any interviewees talk about the impact of the Global Gag Rule on Nepal's abortion law, considering that it's the most liberal of the three countries, and the country made the decision to liberalize the law to save lives?
Although interviewees didn't raise this issue directly, some were concerned that GGR could impact the government policy on expansion on free abortion services. So that was the major concern that some of the interviewees had, but they didn't raise the issue about the impact of GGR on Nepal's abortion law.
And do you think that it had a negative effect on did it actually kind of go against what the government was trying to do? Did you see that impact?
Yes,
So,
let me answer on this. Hello, I'm Anand Tamang. The impact of the GGR, the chilling effect was visible in terms of, the government reluctance to expand the services, the safe abortion services, which is now free in the public sector. And then there are many outreach health facilities which has been ignored by the health systems in terms of accreditation and also, monitoring of the services. We have, many health facilities in the remote areas of the country where the safe abortion services in the public sector has stopped, and the reason behind is that the local government and the provincial level governments are not being informed, or there has been a weak coordination between the federal government, which normally decides where, when, and when to expand the services, and with the local government. So there is some sort of reluctance, perhaps, in terms of translating the policy into action in Nepal.
Thank you.
Thank you.
Thank you very much. For APHRC, can you say a bit more about how the Global Gag Rule exacerbates confusion about whether abortion is legal in Kenya?
Thank you so much, Cherry.
Sure.
So, of course, in Kenya, it's important to first of all note that the Global Gag Rule is actually more restrictive than the abortion law in the country. The abortion law in the country permits abortion to save, or when the woman's life or health is at risk. However, the Global Gag Rule does not permit that. Now, the context already in Kenya is that we have a constitution that gives those provisions for abortion, whereas the penal code introduces the threat of jail to either the provider or the patient. So when you add the Global Gag Rule as an additional layer to this confused legal status, it then makes both providers and women a bit uncertain as to what exact services they're supposed to provide, both within the GGR and outside of the GGR. And it introduces the question as to the permissibility of post-abortion care. The overall effect is that providers are largely afraid, providers and NGOs are largely afraid to engage in any services that may be construed as promoting safe abortion services. In one particular instance, it was even difficult to let's say, engage in the purchase or transportation of materials and tools and commodities seen as for abortion, yet they should be for PAC. I'll give you an example. So you would use an MVA, for instance, to treat an incomplete abortion, yet there are certain cases where the same procedures may be used to actually induce an abortion. So the whole context is exacerbated by the GGR in the sense that women now are unable to get services that ordinarily they would get just because we have this policy that sort of blanketly prevents or prohibits service provision in as far as safe abortion services is concerned.
Thank you so much.
Thank you.
Terry, if you allow me, I just jump in a little bit. And and also add the fact that even the exceptions where abortion is allowed in Kenya, because there is no education for providers and for the public on what is acceptable and what is legal under the constitution and other status, it becomes difficult for providers, given the overall context that abortion is seen as something that is foreign to our settings. People are stigmatized, and because of that, they are afraid to even ask questions. Providers are afraid that they can't be stigmatized by other providers and can be persecuted by the government. Or well, I wanted to say prosecuted, but persecuted might also work in this case. So I think that maybe it would be important to have some kind of discussion or some kind of intervention around educating providers on what is permissible within the law.
Thank you. I think in a minute, we're going to turn back to some mitigation tactics, but thank you very much. Let me ask Mom, you mentioned patients being upset about not being able to receive contraception. To what extent do they understand that this has to do with the Global Gag Rule? That they can't receive services because the Global Gag Rule is in place? I think you're muted.
Merci beaucoup.
Thank you. Thank you very much. For the case of Madagascar, I would say that women, yes, are very frustrated when they can't, for example, go to a health service or health clinic and receive their contraceptive method of choice or what they usually use. And then they go back home without having received any contraceptives or the product that they were looking for. So this does, in fact, create a lot of frustration amongst these women. But during all the interviews that we had with these women and with service providers and benefit recipients of care, we saw that mostly women clients didn't really understand. They didn't understand at all. They didn't understand what the cause was or why they were in this situation. They are simply experiencing this situation, but they really don't have an understanding of what's behind it all. And so if, for example, they ask for an explanation or they try to get more information from the service provider, even the providers often aren't really aware of the situation or are not fully informed. So it's not, I would say that even all the providers are not really fully aware of why there's this disruption with contraceptive products and the fact that it's linked to the Global Gag Rule. So there's a lack of information on both sides. And so the women, the clients, they really don't understand what's going on. They don't know what is behind all this. And as a result, during our interviews, when we were collecting data, after we held these interviews, women would tell us, well, what's the cause for these disruptions, the supply disruptions? And we tried to explain to them what the Global Gag Rule was and the impact. And then they were sort of surprised because they weren't able to really draw a direct relationship between abortion and the lack of contraceptives. They said, well, but this rule is for abortions. We don't understand why we're being penalized. People who are using contraceptives, why are we being penalized when this has something to do with abortion, not contraception? So that was the other perspective that we saw from them. Thank you.
Thank you so much. I guess, a question for all of the groups, and we can go in the same order as we went with the questions. With CREHPA first is, quite apart from having a new president in the United States, how can we actually reduce the harm for each country? What do you think is the best strategy or one of the most important harm mitigation paths forward?
Okay, so since our study found that certifying NGOs were reluctant to provide safe abortion referrals, even under the conditions allowed by the policy, I think passive referral is an important strategy that can mitigate the harm caused by the policy. And just to give a background, even in Nepal, even though we have abortion is legalized, and women still seek unsafe abortion, and one of the reasons is they don't know where to go. And in this context, NGO referrals from the especially from the community-based volunteers who work for these NGOs, they could be like for compliant NGOs or non-compliant NGOs, it's very, very important. So it's very crucial that they give proper information, correct information to women on where they can access safe abortion services. So we think that passive referral is an important strategy that can reduce the harm.
Thank you so much. Okay, how about APHRC? What are your thoughts on this?
Thanks a lot, Terry. Now, owing to what our study found was in terms of the multi-layered effects, we believe that the government of Kenya can actually play a very leading role in terms of widely disseminating the recently reenacted standards and guidelines for comprehensive sexual reproductive health that includes abortion. Of course, these guidelines would offer clarity on the legal abortion services to all stakeholders in the space. And then the next level is at the county level. So of course, to make sure that the national and the county governments increase the budgetary allocations to sexual and reproductive health, including commodities and supplies at the county level, to plug in the gaps that are exacerbated by the expanded GGR. That I consider as the most important, but of course there are others here.
Of course, thank you, Janet. And Mom, in Madagascar?
Well, I think for Madagascar, just as somebody was saying earlier, our country is a very poor country, and so for abortions, we rely heavily on foreign aid. But I think that with the GGR and the fact that it was expanded, our decision makers, our politicians have tried to see what they can do to mitigate the risk or the harm that's being caused by this rule. Of course, it's synonymous, but they're trying to do what they can. For example, starting in 2018, the government allocated a budget, and the government's budget included resources for the purchase of supplies and inputs, contraceptive products. So this budget was increased, and there was an increase every year. So in 2018, for example, it was $32 million. Of course, that's not very much, but it was that was in 2018, 2019, it doubled. So it was $32,000, and then up to 70,000. So it's not much. It's not nearly enough with respect to the needs of the country, but at least shows that the government is trying to do something to help mitigate the risks or the harm of this impact of this rule, and that's primarily the main actions that have been undertaken to try to mitigate this impact, this negative impact in Madagascar. Thank you.
Thank you. Thank you. We have a lot of questions, so I'm going to put 3 out there and try to speak slowly for the translation. One question is, could Bonnie explain the two pathways by which organizations lost access to funding again? That's one question. To Nepal, do you know if any organizations that comply with the GGR, do you know if any organizations that comply with the GGR are receiving the funding that, or I think this question is, who's getting the money that is not being given to groups that are refusing to sign? And then lastly, in this first batch, if the gag rule is rescinded in January by a new US president, do you think there will be lasting damage? And how quickly do you think the impacts you described can be reversed? What measures must the new administration take? And there's another one, but I'll run through those first three again. Bonnie, can you explain the two pathways by which organizations lost access to funding? Nepal, where does the money go when groups refuse to comply? And lastly, long-lasting effects of the global gag rule if there is a new US president and he rescinds the gag rule. What are some things that could be done? So maybe Bonnie, to you first.
Yes, please. Thank you very much. Yes, we could identify two clear ways in which organizations lost access to funding due to the global gag rule. The first is that organizations that refuse to sign the global gag rule, even if they had received U.S. government funding in the past, they lost that. Even if they had been prime partners or sub-grantees of U.S. government funding, they lost that because they can no longer hold U.S. government funding and still provide abortion care or abortion advocacy or anything related to abortion. So in that sense, they have to lost the money. But beyond that, U.S. government beneficiaries, the ones who receive funding from the U.S. government must also forfeit other funding that would have come from other maybe bilateral organizations or bilateral funding, because while the U.S. government provides the biggest chunk of funding for global health, there are other players in the space. It might not be an ocean, but the little drop that other funding would have been dealing with is lost in that way. So lost because you refuse to sign the global gag rule and you are continuing to provide abortion services, but also lost because you signed and you can't get funding from other parts. I could say that some of the other questions that also I could find some interesting part there to say we think that I don't know whether I'm jumping the question here, but I think that we think that if the global gag rule was rescinded today, it will not be an immediate return to positive. For example, we know that down here in many parts of Africa, in Kenya, in Nigeria, the situation is difficult. The context is difficult. So any shake, any disruption to the system will take a lot of advocacy and a lot of work to rebuild and take it back to even the status it was before the introduction of the global gag rule. So I think that the impacts will not just be in the Trump's government or a Republican government. Is going to be long. It's going to be felt long after the end of the government, whether it's in January or it's in the next 4 years. The impact is going to be longer than we see now.
Thank you very much, Bonnie. So for CREHPA, does the money that's lost to organizations that don't certify the global gag rule go to the groups that do, or does it go somewhere else? Do you know?
In one instance, one organization said that they were asked to sign and then they refused. So in that case, it went to another organization. But in most of the cases, because there's a time gap between, if someone says, no, we're not going to comply to the policy, then it may go to someone else. So because of the time gap, it was very difficult to track. So we saw that only in one instance. Otherwise, we don't, yeah.
Thank you. Mom, any thoughts on if the Global Gag Rule is rescinded, how long, what will happen in Madagascar? Will there be a long-lasting impact? Are there steps that can be taken quickly?
Alors, écoutez, je pense moi que.
Well, I think that what we're living through right now, I think it's not just the impact of the GGR. I think that and we're not seeing the full impact right now is what I'm saying. I think that the worst is yet to come. Right now, we're seeing perhaps some of the minor impacts, but I think that the worst is yet to come in 3 years, in 5 years, 6 years. I think that the impact of this is going to stay for quite a while. But the GGR, if it is withdrawn by the new president, I think it will still take some time for us to be able to advocate and to get information out and adapt documents and policies. So I think that the impact of the GGR is going to be here for a long time. But I think also that we're going to keep feeling it gradually, little by little. It'll build on itself. And I think we're going to see new problems come about that are related to this if it's not withdrawn.
Thank you.
Thank you.
Thank you. I have another question for you, Mom, which is, can you explain how unsafe abortion were impacted? How did this impact manifest, unsafe abortion?
D'accord, merci beaucoup. Alors,
yes,
pour ici à Madagascar,
thank you. Here in Madagascar, abortion is not legal or authorized. It's illegal, no matter what the reason is for the abortion. So there are people who want to have an abortion, or they want to change the laws. And we've talked about the laws. We've tried to advocate at the National Assembly, but they've refused to change the laws. And so the situation with abortion is very tenuous in Madagascar. The reality is that it does exist. People are having abortions in cities and towns and villages. People are using products, that are plants, herbs, that can sometimes be very dangerous for the woman. And they are used when the Global Gag Rule was expanded, as we were saying earlier. Women are having more and more difficulty being able to have access to contraceptive products, and the fact that they can't access contraceptives means that we have more unwanted pregnancies, and so women feel that they don't have a choice. They no longer have a choice, and except to have an abortion. And since abortion is illegal, it's illegal in Madagascar, then they do it in very dangerous conditions with traditional providers, with concoctions of herbs and traditional medicines. And so this is where we've seen a huge increase in the risk related to dangerous abortions. Thank you.
Thank you so much. We have only a few minutes left for the question, so I'm going to ask a question that I find really heartbreaking, but I'll ask. Can you any of you say more about the financial and time burdens and actually how much you've been diverted from research that would create progress for pregnant people, women and girls. How has the Global Gag Rule caused organizations, projects, and women's health setbacks? And Annie, we only have 2 minutes, so if anybody wants to go first, please do. Maybe I'll call on CREHPA again. No.
Maybe Anand would like to answer this question.
No, please go ahead. How much time and time has this cost all of you? No.
Sorry,
Okay, Bonnie.
Could you ask that question again? I think I
Yeah, sure. Sorry. I mean, basically, the question is how much effort how much harm has the Global Gag Rule done to all of these organizations? How much time and effort and chaos has it created?
Terry, I think that it requires a longer time to know the full impact that the policy will have on the organizations. But for now, not just organizations, health facilities, you know, some of the NGOs that we included in our study are the ones that provide support to health facilities on the ground. So while we have been talking about organizations, the impact is real on the ground, because if these organizations are unable to provide training to providers in health facilities who deal directly with clients, then the services that whatever services are provided to clients is not, it cannot be the same as what will be provided if there were some funds available for training of providers. And of course, we hear that there are a lot of stalkers. For example, when we talk to women and girls, they knew that something was wrong. They were missing situations where the services that they used to get, they can't get, but they were unable to say that it's because of the Global Gag Rule. While we know that, we can extrapolate the information that we have from our research to say, well, the Global Gag Rule is not just affecting organizations that receive money and do and implement programmatic activities on SRO, HRO, and abortion, or even HIV, because of the disintegration of services, but it also affects people on the ground. The downstream part of the impact is the actual women and girls who are unable to get family planning services, who are unable to get abortion and post-abortion care services. And it will take a little bit of time, even though our study here has shown what I will say is the early impacts of the Global Gag Rule. I think that over the next 4 years or 10 years, then we will see what this has really cost. And in terms of abortion specifically, it might even require a study, maybe a nationally representative study on maybe the incidence of abortion or of unplanned pregnancies to have some idea about what the impact of this will be.
Thank you very much. So sadly, we're out of time. We have many more questions. I am going to turn it over to Neha Raval to talk about in-country dissemination. I just want to quickly say what a great honor it was for us at Columbia to work with you partners on this research. Neha.
Thank you so much, Terry, and thank you to our brilliant partners. I just want to quickly touch base about some of the dissemination that we also participated in during this research project. So we worked closely with advocacy partners in both Kenya and Nepal to disseminate the findings and on harm mitigation activities in each country. In Kenya, we partnered with Planned Parenthood Global, or PPG. PPG has amplified the Kenya research results, the paper, and the commentary across social media, and research results have been used to support local and global advocacy efforts. They have also created fact sheets. Once finalized, they will be available for dissemination and shared with advocacy and service delivery partners and coalitions. Additionally, PPG has convened a steering committee of Kenyan doctors, advocates, champions, and researchers to disseminate the findings. This group will strategically plan how the findings inform Kenyan and global advocacy activities and goals, and identify roles for champions, media, and others involved. Next slide, please. In Nepal, we had the honor to partner with IPAS Nepal and MSI Nepal. The partnership with IPAS Nepal included trainings with school health teachers on adolescent sexual and reproductive health, safe abortion services, as you can see in the photo on the right. IPAS also conducted trainings with local officials on safe abortion services and conducted social behavior change activities. Lastly, MSI Nepal created publications about GGR in regards to referrals and funding, and conducted a meeting between lawyers and chief district officers. We truly look forward to continued advocacy partnership and translating all of the research for action. I'll now pass the mic to my colleague, Dr. Sarah Casey, Assistant Professor, Population and Family Health at the Columbia University Medical Center. Thank you.
Hi, in addition to the 4 research articles which we've presented today, we also have in the special issue 5 perspectives or commentaries from advocates, lawyers, and practitioners from the Global South and North that describe the harmful impact of GGR on their work. Next slide. So in these commentaries, we hear the perspective of a young woman in Nepal working to reduce abortion stigma among adolescents, and how GGR is impacting her work to push the government of Nepal to include adolescents in their work, to increase access for them. A human rights lawyer in Kenya describes the impact of GGR on SRHR advocacy in Kenya and calls on the Kenyan government to ensure that services permitted under the Constitution, including safe abortion, are provided regardless of outside influence. 3 lawyers from the US and Zimbabwe call on their fellow lawyers in countries that receive US global health assistance to reduce the harm caused by GGR by using national law to preserve access to services. Advocates from Kenya, Nepal, and the US discuss the reinforcing harms of COVID-19 and US foreign policy to abortion in Nepal and Kenya, including describing how these policies are vestiges of imperialism in the Global South. And finally, although US humanitarian assistance is supposed to be exempt from GGR, humanitarian actors describe Global Gag Rule's negative impact on humanitarian best practices by reducing effective collaboration across the humanitarian development nexus, impeding localization efforts, discouraging the integration of health services, including sexual and reproductive health, which ultimately result in negative health impacts for people affected by war or natural disaster. So do make sure to check out the commentaries and perspectives as well. I'd now like to introduce Esther Kismodi, the Chief Executive of Sexual and Reproductive Health Matters, to close our webinar.
Thank you so much for this fantastic webinar, and for all participants, and also for Terry and Sarah for your program of organizing it and having with research. We are extremely pleased, humbled, and proud of this collaboration, and we are so hopeful that the information, both in terms of evidence and analysis, whether we take the research articles or the perspective basis, will really contribute to a further understanding of the impact of the Global Gag Rule and will lead to policy and service delivery changes. SRHM as a multidisciplinary journal and more than a journal space, we will make sure that we reach out to service providers, policymakers, advocates, human rights activists in the field to disseminate this information. And we really, really hope that, this information will hugely contribute to policy changes in the US as well. Thank you so much again for this collaboration, also for colleagues in Madagascar, Nepal, and Kenya, and in other places in the world. And we also hope that your work will provide a methodology for documentation in other countries as well. Thank you so much for everyone.